Welcome. Welcome to the Health System Performance Network monthly webinar. Really pleased to have everybody joining us today. We have a really great lineup today of speakers from locally driven population health models. So this is about local innovation in population health with an equity focus. Please join us and let us know where you're joining us from. So if you could go to the chat, make sure you set the response to everyone, and then send a note and let us know where you're joining us from. I'll just watch as people join in. Just Louis Fliss from Flemington Park. You're here to see your own colleagues as well as others. Sue Connell from Hamilton. Welcome to Rebecca from KW4. Joe DeRoche from North Simcoe. People are finding it. We have just over 75. As soon as I say a number, there's already more people joining us today. Stephanie from Sudbury, Wendy Jerry is a regular to our webinars. I think maybe one of our most regular attenders. Jen Pickett from OH West, welcome. Stephanie Bale from Sudbury. People are coming in now. Leslie McGough, thank you from Rise. Welcome. Catherine from Sloth. I'm not sure what that acronym is, so maybe somebody else does. Nancy from Care First. We'll hear from Care First today. Dean from Downtown East. Welcome. Please continue to enter into the chat who you are and where you're from. That is the way that we know who is all joining us today. So it's really helpful for us to have the chance in the chat, because you will see us, but we don't otherwise see you. And so it's a real chance for everybody participating today to see that we have people coming from many parts across the province. Denise, welcome from Alderville First Nation. Chelsea from Toronto. Alexandra from the Ottawa East. Équipe Santé Ontario. Welcome. Okay, thank you very much for joining us today. I am speaking to you today from the University of Toronto, and for many years, the University of Toronto, thousands of years, has been rightly the lands of Indigenous peoples, including the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. And we're very fortunate to use this land today for activities like research, evaluation, and hosting these monthly webinars. It's still home to many Indigenous people from across Turtle Island, and we're grateful to have the opportunity to work on this land and to join you and host you today. We have a great lineup today, and I'm not sure if you've participated before, so we're going to just pop out a little poll here, and you can let us know if you have participated in a webinar previously. Yes, you have, or no, this is your first event. Please add your votes, and I'll have to watch to my colleagues, Myra and Tricia, and monitoring this today to be able to tell. We have over 106. There's more, 107 participants. Every time I call out a number, there's more people joining. And once we have, maybe about 70% or so of people, or you see votes coming down, and if you can share that out. Okay, we have 40%, which is coming for the first time today, which is above usual. Usually we're no higher than 30. We have plenty of returning. And I think that is the topic area. And to me, this is just wonderful that we are reaching new people and new participants across the province. So welcome, and I hope that you will find today to be both a learning experience and also a fun time. I think we have a lot of really exciting materials coming your way, and please feel free to join in the chat. We like to keep a pretty active chat running during these events. You'll see today's event has many people participating. So we have from Flemington CHC, which is in East Toronto, Mussarat Ijaz, who's the manager of population health and wellness. And over the past 2 years, she successfully led and expanded the Community Health Ambassador Program in collaboration with a couple of Ontario Health teams, East Toronto and North York. Joined as well with Hama Mughal, who's a community health worker at Flemington, and she's closely working with the health ambassadors and coordinating the East Effort program. We have from Care First Seniors Community Services for Sherilyn Hugh, who's the Director of Development and Clinical Care. She's also Executive Director of the Care First Family Health Team, been co-leading alongside valued partners the equity-based, community-driven population health initiatives, including the locally driven population health models. Joined today with Nathan Shan, who's the CEO of the Tamil Canadian Centre for Civic Action, a longtime educator and community organizer, and leads a number of organizations. There's a long list of organizations, including the South Asian Health Alliance, Urban Alliance on Race Relations, and Tamil Canadian Centre. From Ottawa, Southeast Ottawa, we have Amanda Bonacci, Fatima Andad, and Rana Tahir, who are joining us. Amanda is the Director of Community and Social Services at the Southeast Ottawa CHC, and has been in this role for 6 years, leading a variety of high-priority community strategies throughout COVID and after. Fatima Andad, the mental well-being coordinator for the Community Development Framework, collaborating with partners and residents in priority neighborhoods across the city, along with Rana Tahir, who began as a dedicated volunteer and blossomed into a role as resident leader and community ambassador in Ottawa. So really looking forward to hearing from all of these. You're also going to hear from Lale Rashidian from the Health System Performance Network, who will overview some of the programs in general as we start to undertake a bit of an evaluation of these programs, and which is how we are coming to learn about the programs and just the amazing work that they're doing. Finally, certainly not least though, Sophia Kura, who's Executive Director and the founder of Health Commons Solutions Lab. And Health Commons has been supporting as a backbone organization all of the originally high priority community strategies from their origins and now through to the locally driven population health model. So really, you're going to hear from a lot of people today, and really, I think, get a good sense of what different people are doing across these groups. Just before we summarize what they're doing, I want to know from your participation, the people who are participating in the audience today, to what extent are community individuals involved in designing health initiatives in your settings? So to what how are you engaging with community members? Are you having them lead or co-lead programs, consulting with them, providing input, or are you sort of informing them? Or at present, are they not involved at all? So from your organizations and your perspectives, what is the level of involvement? And again, I'll watch to the team to catch up, and I look forward to hearing from your perspectives and your organizations the extent of community member involvement in your programs in your neighborhoods. Because one of the things about the locally driven is that they are very much engaged with community in co-designing and meeting the needs and identifying what the purposes are. How are we doing with the poll? I'll wait until the people watching the poll can tell how many people have entered into it. We're up over 135 people now joining us today. So I really look forward to hearing from you, both through this, but then in the chat, what you're learning and questions that you may have for the speakers along the way. If I can share up this. So our most common engagement with community members are regularly consulted during the development, which is just a great to see that people are being involved in the design phase and deeply involved. And some people are still not being involved, and we'll understand better today why it's so important to be involving community members in your work. I am going to turn it over then to Lale. We've done our introductions. Lale's going to give a bit of an overview, and then we're going to learn from 3 community agencies as I summarized there. And then finally, Health Commons, and we'll open it up for panel discussion and Q&A along the way, but also at the end. Lale, over to you.
Thank you, Walter. Hi, everyone. I'm delighted to be here. My name is Lada Rashidian. I'm a PhD candidate at the University of Toronto, and I'm very grateful to have the opportunity to work at the Health System Performance Network. And as Walter mentioned, we are currently in the process of evaluating the locally driven population health models, which were formerly known as the high priority community strategies. So I'm sure that many of you on the call are familiar with these names, either with the high priority community strategies or with the locally driven population health models. But for those of you that aren't, we just want to give you a sense of what these programs wanted to achieve, what they've been doing, areas that they've been focusing on, as well as impacts that they've had on indicators related to health and access to care within their communities. So the locally driven population health models, what they are doing is they are trying to use resources that exist within communities, such as health organizations, social services organizations. So really using what is already there, and then going back to their communities and involving them, trying to see what it is that they need, the health requirements that they have, and figuring out a way to provide them with care that they need in a way that is culturally responsive. So across Ontario, we have a very diverse population. Obviously, the health needs vary for different populations, as well as the ways this care needs to be provided in order to be suitable varies. So this is what the locally driven population health models are trying to get at, giving people what they need in the way they need it and using the existing frameworks to do so. Now, these models weren't really developed in a vacuum. They've been going on for a number of years now. So initially, this blossomed from what was known as the high priority community strategies. The high priority community strategies happened in the thick of the COVID pandemic. So at the time, what they did was they went into the communities that had been hardest hit, that is, communities that had the highest rates of COVID, but also had the lowest rates of screening. So even though they needed access to care, we observed lower access to care in these populations. So within these communities, they did the same approach. So they used the pre-existing partnerships, they used these resources, and they provided care in the way that it needed to be provided in order to allow people to address COVID needs. So whether that be providing people with testing kits, providing them with PPE, providing them with wraparound supports, giving them a space to isolate if they needed it. And over time, so in April 2022, when the pandemic was kind of dying down and they were able to kind of move the resources to other areas of health, this evolved into the locally driven population health models. So what they're doing now is they're trying to use these systems to make sure that people are getting chronic disease prevention, meaning if they're at an age that they're eligible for cancer screening, they know about it and they're able to get it. If they need to be screened for diabetes, they're able to get it. If they live in a vulnerable community and they do not have access to a family physician, these models helps them to achieve primary care attachment. People struggling with mental health and addictions, they receive referrals. If they need naloxone kits, they get them. And overall, within these communities, we observe a lot of different needs, not always necessarily health-related. So wraparound supports, meaning helping people with food needs, helping them with transport requirements, for example, and just overall health needs within these communities. Okay. So as mentioned, it's been running since COVID, and there were initially 16 agencies that were involved in the rollout of what was initially the high priorities and now the LDPHM. And we have a map of them here to kind of give you a sense of how they were spread out. So we have a few in Toronto, a few in our surrounding areas, one in Ottawa. And as I know now that there are a few more than 16, but these were the original 16 involved. And as part of our evaluation, what we did was we chose a few of these agencies and went and did a much deeper dive to get a better understanding of what it is they're doing, why it's working, why some initiatives did not work as well as they should have done, and just getting a sense of barriers and facilitators for success in these communities. And that is how we came to learn much more about the 3 agencies that we are very lucky to be hearing from today. So we have Flemington, the Care for Seniors, and the Southeast Ottawa CHC. So we talked a bit about how they came to be and what they're trying to use, but just to give you a sense of overall activities that are carried out as part of the locally driven models, there is a lot of overlap between these different categories. But for example, they are bringing services to the community. So an example of that would be in the Windsor Essex community. They set up a mobile van, and this mobile van moves around in the community, provides people with testing if they need it. If they need help filling out forms, they help them do that. If they need referrals, they do that for them. They do pregnancy tests, STI testing. So a whole range of different care that is provided in this van and just moves around and is accessible to everyone. Other things they do is they use the community ambassadors, so trusted individuals within the communities to allow us to make these links and provide people with care that they need to do. Partnering with primary care, coordinating referrals. So an example of one activity that uses all of these is in the Indus Community Centre, they set up a hotline where people who don't have a family physician call in, they're connected to a community ambassador, so someone they might know. And this community ambassador links them with a physician who is accepting new clients. So they're able to make that connection, but through a trusted person. Education and communication. So this is both events for people in communities as well as for providers. We heard from the Southeast Ottawa Community Health Centre that they were informing the physicians of what services were available. Oftentimes the physicians don't know about the social services that are available to their communities, as well as expanding partnerships for wraparound supports. So in the Dixie Blur area, they set up food banks for people who might be struggling with food availability. So we talked a bit about different activities. So just to give you a sense of the impact that these have. So this is data that is self-reported by the agencies themselves. And this is related to Q4 of the 2023-2024 fiscal year. So in that quarter, across all these 16 agencies, they observed that over 2,250 new partnerships were formed across 10 sectors. Over 290,000 engagements, interactions with people within the community. 57,000 were referred for wraparound supports, and 29,000 of these actually received wraparound supports. They referred almost 10,000 people to primary care, of which 2,000 of them were successfully attached to a family physician. Over 17,000 were referred for cancer screening, and over 17,000 referred for mental health and addiction support, with over 1,000 naloxone kits distributed. So obviously you can see these models are actually making a difference. They're allowing people to be attached, people are receiving the screening they need to be. And just to go into these numbers a little bit, so we talked about over 2,000 new partnerships. So when we talk about partnerships, what we mean is that an organization is either informed of efforts that are going on in that area, they're consulted, they're involved, or they might be a co-delivery partner. So if we break down those 2,200 partnerships, we can see that 21% of them were with organizations that weren't necessarily health related. So we have faith organizations, sports and cultural organizations. 21% were with social services. A further 20% were with newcomer and settlement agencies. And then we do see like partnerships with diabetes education programs, with acute care, with family health teams, family health groups, for example, or even laboratories. We see that a large chunk of these partnerships are with social organizations and not necessarily related directly to health. And also 291,000 interactions with people in the community. So how does this come about? When we go into the numbers a little bit, we see that 40% of them were people that were reached through either social media, print media, such as brochures, for example, or broadcasts on their local networks. 34% of them were people that directly interacted with a community ambassador in their region. 10% of them participated in educational sessions, 6% of them logged in onto webinars, and the remainder were reached through different pathways. So as you can see, it's a wide variety of methods, different things. So we have vans, we have events, we have hotlines. The thing about the community, the locally driven models is because they cater directly to their community and they know exactly what it is, it leaves room for innovation and creativity in a way that's honestly fascinating to see. And with that, we'll hand it over to Walter to introduce the Flemington Health participants.
Fantastic. Thank you very much. Yeah, and it is amazing to see the impact of collective community-based action. And we can really see it through these organizations, the many statistics there of 16 agencies in just 3 months, and an incredible impact leveraging the strengths of community. So now we're going to learn about how some of those programs are actually working on the ground, how they've been created and shared over time. Starting with Flemington, Dr. Ijaz and Hamna Mughal to share with us what's happening in Flemington. Thank you very much. Over to you.
Thank you so much. Hi, everyone. I'm Hamna, and Masud and I will be getting started. If you could get to the next slide. Awesome. The next one. So today we'll be talking about most specifically the East Effort program and highlighting the community ambassador work that we've done collectively. So I believe Lali spent a really great, she spent time articulating in a really great way the evolution of the high priority communities funding. And as a result of the funding, the East Effort program began in 2021 as a response to the health inequities during the COVID pandemic. And in the beginning, I would say we focused most specifically on 3 pillars, which was community outreach and education, and increasing awareness of COVID-19 and a reduce of transmission, and also access to testing and wraparound support to remove barriers and prevention, including isolation. However, what we implemented was unique. We really would like to highlight how we were able to do that work on the ground, which was through the hundreds of community health ambassadors hired across different neighborhoods within East Toronto to help design and implement the program on the ground. The community health ambassadors were folks that had lived experience and in the communities that spoke different languages and came from different cultural backgrounds, and they had dealt with health inequities, or they were involved in grassroots organizations advocating for social determinants of health. And the outcome of this approach was staggering. The neighborhoods went from areas with some of the lowest COVID vaccination rates in Toronto to some of the highest. And the health system had finally caught up to something we had always known, the peer programs that have a considerable impact on people's lives. It became evident that the CHA program must be embedded in supporting social determinants of health and chronic disease and primary care gaps and lots more. And FHC advocated alongside other partners to ensure we get baseline funding, which has now led us to a point, as Lali was where we continue to build CHA sustainability. The next slide. Perfect. So this image illustrates the structure of East Effort and partnerships at each level, highlighting from bottom to top an approach of for the community, by the community. And you can see collective achievements in neighborhoods of East Toronto, most specifically Oak Ridge, Warden Woods, Taylor Massey, Crescent Town, Flemington, and Thorncliffe Park. And this is due to the partnerships across the board. We really want to acknowledge our partners, and that is the Neighborhood Organization, Wood Green, Access Alliance, the Neighborhood Group, along with our team at Flemington Health Center. And just very quickly, I also want to acknowledge the efforts, no pun intended, of our East Effort Steering Committee. They support with decision-making and setting guidelines and principles that allow for equity and funding distribution, and bring an expert lens from different organizations such as South Riverdale or our partners at East Toronto Health Partners and Michael Guerin, that are able to make informed decisions that are both evident on the systems level, but also needs of the ground. And I will pass it to my colleague, Masud.
Thank you so much, Hamna. Just wanted to kind of talk about the learning health systems approach used in the East Effort model, a data-driven approach to identify and address the needs of the communities, enabled with a culture of and competencies for rapid learning and improvement. With the data known, East Toronto's population is more than 50% immigrants, and We have seen, and it has been recorded by the Ontario Screening Performance Report 2023, that there is a disparity that is noted between the cancer screenings in various neighborhoods, notably more vulnerable neighborhoods with low socioeconomic background and a higher rate of immigrants or newcomers in the population and the communities, showing less screening rates as compared to affluent neighborhoods. Understanding the needs of the community has enabled solution design around the community. Deeper analysis showed the key barriers, which were difficulty in accessing services, language constraints, and a lack of knowledge about the importance of screening. Demographic and culture also played a role in the health practices, and there was a need that was seen to address misinformation about cancer screening. Recognizing these disparities, community health ambassadors were trained to provide culturally adapted education, language support, and outreach to improve cancer screening rates. I wanted to acknowledge our colleagues at Health Commons who designed a lot of modules and trainings that were supportive in this trainings for the health ambassadors. I'm gonna move on to the next slide. This slide basically identifies the critical issues of delayed and inequitable cancer screening, exacerbated by the pandemic, particularly affecting certain racial and income groups. It presents current screening rate for pap tests, mammograms, and colorectal screenings, showing modest improvements targeted for 23-24. The plan focused, based on the realization of the disparities, a multifaceted approach was taken to address the above issues, which was using PoppyBot, which is a robotic process automation tool that uses primary care electronic medical records, EMRs, to identify and segment people who are due or overdue for cancer screening. PoppyBot has helped identify in East Toronto around over 15,000 people for screening. So the two approaches were to utilize PoppyBot to identify and flag those who were due or overdue for screening. And the other approach was to utilize our community health ambassadors to conduct targeted outreach to residents in communities with lower cancer screening rates. The cancer screening awareness, no. So based on all the above realizations, a unique framework was developed, which was the Cancer Screening Awareness Blueprint. This was done collaboratively by Flemington Health Centre, East Toronto Health Partners, Behavioral Insights team, and our Health Commons team. The CHAs were identified and based on the languages that they were proficient with, based on the PoppyBot identifying the different ethnicities that were low in cancer screening in these neighborhoods. We identified folks that were speaking Arabic, Slovak, Urdu, Bengali, Pashto, Dari. So these were identified with lower cancer screening rates. The health ambassadors engage in efforts including language-specific outreach in multiple languages, personalized client support for booking and education, and mobile screening events to increase accessibility. Communications were carefully designed to respect cultural sensitivities, avoiding stigmatizing language. These strategies have successfully motivated over 1,000 individuals. They were previously reluctant residents to participate in cancer screening, highlighting the power of culturally tailored community engagement. Now, a quick snapshot into the Cancer Screening Awareness Blueprint. This serves as a practical guide for community health ambassadors at Flemington Health Centre. It outlines a structured approach to initiating conversations about breast, cervical, and colorectal cancers, cancer screenings, including how to start discussions, address common questions, and provide helpful information about screening, locations, and resources. This blueprint ensures CHAs are well prepared to deliver consistent, culturally sensitive messaging that empowers community members to take proactive steps towards their health. This is the community testimonials for cancer screening. It just highlights the positive impact of community health ambassadors in increasing cancer screening awareness and participation. With that, I will hand it over to Hamna.
Thank you, Ms. Harith. And we are happy to share the blueprint. It's available online. We're currently updating it because the health ambassadors have spent a significant time in the past year doing outreach in the community, where they've been able to make some more additions to the blueprint. But happy to share that because it is definitely one of a kind tool to be utilized in cancer screening awareness. All right, so this is a really important story for us to highlight because in early 2025, a growing number of student suspensions were taking place at Mark Arnault Collegiate, and that revealed a deeper issue. Many students were being excluded from school simply because their immunization records were missing or incomplete. With about 114 students at risk of suspension, it was clear that families were struggling to navigate the public health requirements, especially in communities where language and system barriers are common, and we have lots of newcomers and refugees as well attending the school. So in partnership with the integrated primary care team at FHC, our community health ambassadors stepped in quickly and effectively, drawing on deep community ties and cultural knowledge, along with up-to-date trainings from TPH on updating immunization records online. And CHAs were then able to provide language-specific support to families from diverse backgrounds. And they worked directly with parents and caregivers to explain vaccination requirements, support record uploads, and bridge the gap between health protocols and school expectations. They were able to draw in the parents to come onto the school site. We brought the nurses to the school, and we were able to collectively host vaccine days for students, just so they're not getting suspended. And what might have otherwise been a rigid enforcement of health policies became an opportunity for relationship building, trust, and support through this process. CHAs help families feel seen and empowered and not penalized, while also supporting schools and public health teams and reaching their targets. And the results were significant. Suspensions dropped from 114 to just 37 students, a direct outcome of CHA-led outreach and advocacy, I would say. And this initiative was a powerful example of how CHAs are not only rooted in their communities, but are also able to respond with agility to emerging health system challenges and ensuring that equity and care stay at the center of policy. And some of the students that were not able to get vaccinated, they were able to book appointments really soon at access clinics just so they can prevent future suspensions. This is a really powerful story for us because it goes to show that without the health ambassadors, we would have a huge gap in the system. All right, the next slide, please. Oh, if you could just go back one more slide. Awesome, thank you. Thanks to the advocacy and support from many people at this table, as well as others outside of this table, we are now in the position to support unattached community members in getting access to primary care. We're currently focused on M3C FSAs, and CHRs are currently supporting the dissemination and completion of the Ontario Health Survey to further improve primary care access in the community. And this has been a huge success so far. People have been waiting for primary care access. They were talking to the ambassadors about it for some time. So it further allows the health ambassadors to redevelop the trust or to continue developing the trust with the communities that they have been talking about getting connected to primary care needs. And the other important aspect of this work I'd like to highlight is that CHA activities apply the best practice of meeting people where they're at. We hold health and information fairs during cultural and religious festivals like Ramadan or Holi to incorporate culturally relevant outreach is in place. And we can really go and meet people meal in their communities, in their grocery stores, and be accessible to them. And you can see the picture on the far left from one of our last community health fairs that incorporated the culturally relevant approach, and that was during the month of Ramadan, and we incorporated a free grocery giveaway in partnership with some community partners like Project Ramadan, and it was a huge success. And we were able to raise a lot of awareness around community programs as well as the primary care access clinics. And the next slide is another snapshot, and this one specifically focuses on the amount of CHAs that we've deployed. You would see a significant shift since 2023 in comparison to 2021 and 2022, where we had hundreds of CHAs deployed to ensure we have community members getting COVID vaccines. However, we felt in order to have CHA sustainability as well as CHA employment that is able to give them proper hours and equitable pay, we wanted to keep a smaller pool that's able to disseminate itself and be on the ground and build trust one-on-one with community members. We have shrunk the number of CHAs within East Effort, and we're still able to have really impactful numbers in terms of primary care as well as service navigation. The one thing we wanted to highlight today is the client demographic. So we will see that there is a significant Middle Eastern and South Asian population. So a lot of our ambassadors do speak those languages to ensure that they're able to communicate well with the neighborhood, with the community members on the ground. And those languages, most specifically the equity deserving languages, would be Dari, Urdu, Slovak, Bengali, Arabic, and Pashto. And most specifically, those languages were the ones we carried out the cancer screening awareness work with. All right, I'll pass it back to Maseret to talk a little bit about the lessons that we've learned.
Thank you so much, Hamna. Just in the interest of time, I will just go through this slide only. And basically, the lessons learned were early identification of challenges, very importantly, community consultations, the co-design approach that we had utilized in the cancer screening awareness blueprint, transparency and community engagement, community capacity building. This is all through our community health ambassadors that are our eyes and ears within the community, and they bring us all that information that this is the need that they are highlighting within the community. Again, inclusive decision-making, cultural competency, very important because the number of languages spoken in these neighborhoods in East Toronto demands that the cultural sensitivity and competency is takes precedence in all the program designing and implementation. And just a few pictures about the program outcomes. Recognized by North America Conference of Integrated Care 2024 at International Conference on Integrated Care, published case study, How Can We Reach Non-English Speakers for Cancer Screening? And a few pictures or faces behind the East Effort Community Health Ambassador model. With that, I would like to thank for this opportunity. Thank you so much.
Oh, it's just amazing to see the work that that has been happening in East Toronto, and what an incredible diversity of communities that you are partnering with. And I think, you know, I see this as real opportunity for strengths-based community design, as well as, you know, you talked about even more capacity building within the communities. Great to see you at the North American Conference on Integrated Care, and the notion of using a learning health system approach. And I saw the data, I saw, you know, change ideas and evidence-based practice. I saw implementation considerations for behavioral insights and rapid cycle feedback, all of that being really, really key. So thank you so much for sharing along those lines. And really now welcoming to Sherlyn and Nathan to talk about some of the work in the North, East, and Scarborough areas of Toronto through Care First Seniors. Sherlyn, let me turn it over to you.
Thank you so much, Professor Watches, and good afternoon, everyone, and HSPN for your warm welcome. Charlene from Care First. I'm very pleased to co-present with our core partner, Nathan, today. The high priorities community strategies and the locally driven population health model really helps to advance system reform while building healthier, more equitable communities from the ground up. And the key to this success has been strong community-led partnership grounded in local insights, broad collaboration, and adaptability. And Care First had been the community-based lead agency in the eastern part of the central region to roll out with partners the high priorities community strategies when COVID began in 2020 and has continued to lead the LDPHM model and equity-based health initiatives such as our preventative care program, our local Black health initiatives, and anti-racism, inclusive health training and mentorship for health service providers regionally with our OHT partner. Here's what makes Care First unique. Care for Seniors and Community Services Association has evolved over the last 50 years from a single service Meals on Wheels program to a community-based multi-service provider model on the internationally renowned PACE model, Program for All-Inclusive Care for the Elderly. Care First has provided an integrated continuum of health and social care, including intergenerational wellness and preventative care program, community services, such as service navigation and adult day program, primary care, chronic disease management, transitional care in diverse settings, such as families, community hubs, service centers, and with a cutting-edge campus of care housing 124 long-term care beds under development. We work closely with our sister organization, Care First Family Health Team, and together with our partners, we're able to provide wraparound and integrated care for the communities with multiple services and access to primary care. And that's why when Ontario called for localized, equity-informed health solutions, even during the pandemic, Care First didn't need to start from scratch. We just needed to scale up what we already embrace. Now, what is it like on a day-to-day? Here is a snapshot. As you can see from the photos from left to right, Care First paid community ambassadors and social worker work alongside to offer service navigation and warm human connections with clients who access our local food banks. Our ambassador designed and performed skits to create culturally safer community spaces for conversations and care connections on stigmatized mental health topics. We co-hosted health fair, low barrier health fairs with Eastern York Region, North Durham, OHT. Our outreach mobile health clinics have been bringing initially vaccination and testing and currently primary and preventive care such as HPV testing to priority neighborhoods in local plazas, public housing, and faith-based settings and more. And to us, this is the power of a high priorities and locally driven population health model, enabling organizations such as Care First to scale up what we knew works in the community to address system pressures. That is, community-led, equity-driven, integrated, culturally responsive care that promotes health proactively where people are. And none of this happens alone. Equipped with a budget from Ontario Health, Care First has worked hard to foster that peer-to-peer trust-based relationship with more than 40 diverse partners to reach in on the ground, listen, and to act on conditions that support health. As you can see from the table, our partnership network spans a broad continuum of health and social care, including our health partners, especially our OHTs, community support services such as settlement agency, faith-based ethnocultural grassroots organizations, and other sectors including municipality, ethnic media. The scope and the partnership really mirrored the extent and the complexity of the health and social challenges faced by individuals and families that we met. Many of our non-traditional health partners, in fact, stepped up and played a pivotal role during and after COVID as well. We learned that strong partnerships are key, something that has been reinforced actually through cumulative revaluation and knowledge sharing. In fact, in 2022-23, An independent team of experienced scholars conducted multi-method evaluation of the High Priorities Community Strategy model in Southeast Markham. And Care First was proud to share insights also at the North American Conference on Integrated Care last year. And we've co-authored a journal article with Professor Paul Williams and his team on how High Priorities Community Strategies and its evolution really integrates health and social care on the ground. And it's forthcoming in the Healthcare Quarterly, and we look forward to sharing the link once it's out. And now I'd like to invite my partner, Nathan, to share your perspectives on the ground as well. Over to you, Nathan.
Thank you, Charlene, for allowing us to be part of this presentation. For those who are not familiar, Tamil Civic Action works with the Tamil community in Ontario, working on different topics, including health. I'm also coordinating South Asian Health Alliance. South Asian Health Alliance is working to have a provincial strategy around South Asian health, but also does a lot of grassroots work. So we've been part of many different collaborations and partnerships in the past in my work in other organizations as well. So I wanted to kind of talk a little bit about what made this partnership successful, what made this collaboration a successful collaboration, because it's important to learn from models that work. And this is one of the models that, in fact, one of the best examples of a collaboration that I can think of in the last 25 years I've been involved in the not-for-profit sector. I'll say a few words around why. So one of the reasons is the kind of respect that is maintained in this collaboration. There are organizations of different sizes. For example, when we got involved in this collaboration, we were one staff organization with a lot of volunteers. So as a small organization, we never felt that we were less powerful or less impactful in the collaboration. The size did not matter. It was actually in an environment where the organization's voice was always valued. The other piece is the kind of roles that different organizations play. When in health related sector, you often see maybe there's an imbalance from a clinical side, or the expertise is heavily prioritized on the medical side. But in this collaboration, we found that grassroots organizing, community engagement models were also respected and given the priority they deserve as a contributor to the conversation. So I think the size and the roles were not necessarily factors in which we felt less powerful. So that is important to consider while developing these models. The other thing that I found very interesting and as a small organization is that whenever we had meetings, Care First as the lead organization always had the senior leadership present there. So it was not delegated to, working with grassroots organization was not delegated to frontline staff, which is not a bad thing, but at the same time, executive director to executive director, CEO to CEO conversation were always possible. The accessibility of the leadership of the organization was always there. So that I think is a critical piece, because the conversation of what needs to be done, the innovation that needs to be built, were possible because that was always there, and the decision making, access to decision makers of all organizations were present, I think, and the organizations like us who specialized in reaching out to South Asian communities were given the kind of the freedom to develop the model. So we had a lot of focus on ethno-specific media. A lot of the media in the South Asian communities are community-based media that have good reach into certain sections of the population. And as you know, South Asian is a heterogeneous identity of solidarity, not homogeneous, essentialized one type of community. So it allowed the flexibility to have various different ethno-racial, ethno-cultural media outreach, faith outreach, sports and arts-based outreach, and so on. So it allowed the flexibility and the understanding that these methods needs to be employed. The other piece that was very critical for us is the ongoing communication that was always there. And the reason why this connects to health equity is health equity as a form that needs to be implemented in the system, and particularly in the health system, needs to work through a lens of grassroots community-based organizing spaces. So that allowed us to innovate. And today we are offering a mental health program together with Care First, looking at South Asian and Asian communities through very unique, innovative models that use uses art forms in our communities to destigmatize the conversation and have health equity conversations in our communities. And the last few things I want to mention, I know I've just taken 3 minutes to kind of elaborate about the collaboration. I think one of the other things was that there's always conversation about sustainability. Even though the funding was like 6 months, 1 year by the government, we often felt in the group that we are there for long term, we are there with future thinking. And that was important because it was not necessarily seen as a project-based collaboration, but in fact, structural issue where large number of South Asian communities lived around access, equity, and inclusion was being addressed together. So different organizations in the partnership were at different levels with respect to how they understood inclusion, accessibility, and anti-racism work, but there was always this sense of wanting to learn and wanting to grow together, and that is important because I know that work needs to be embedded into all the things that we do, and anti-racist thinking and framework needs to be part of the work. So I think to finish off, one of the great things is that, in North Scarborough and South Markham, where we work together, Asian and South Asian communities have lived together for decades, and they go to same schools, transit and stuff like that, but there has been silos between the communities around coming together. And this particular collaboration has broken those silos and have come together and participated together, learned from each other, learned from shared history of migration, shared history of systemic exclusion in this country as well, and have troubleshooting process together to figure out what is next. So that relationship building has been critical as well. So moving forward, as we move forward, we are hoping that we will be able to work on these things more structurally in removing systemic issues, including health inequities. I'll pass it back to Shirley.
Thank you, Nathan. Thank you for your sharing, actually. And Nathan, your sharing really reflects how the high priorities community strategy and now locally driven population health model partnership worked on the ground to advance local population health. And this is not just a good impact story. In fact, it is a made Ontario model at work, one in which we can really address what matters to someone so that no one has to ever question whether do I even matter in the system. So in brief, I really resonate on the sharing of the how-tos of building trust-based, community-based partnership. It is about a non-hierarchical, peer-to-peer, high-trust relationship partnership building that is facilitated by communication and ongoing access and elevating the voice of the community. It is about a more equitable sharing of resources, be it in our know-hows, the coming together of the clinical and the grassroots and the community funding, social capital, equipment on the day-to-day. It's also about that shared framework of that collective impact in it for the long term, that we can grow together, build our shared capacity so that we can have these innovative approaches that really touch people and build on our shared history and find common roads ahead. And to us, or to, I hope that everyone feels that way too, community-led partnership is also made possible in an empowering policy environment where there is an enabling consistent policy that facilitates local innovation, community-led solutions, and the lens of equity remains embedded in planning. And it's about having also a community-based lead agency who has the connections and the commitment to build local assets and facilitate ongoing growth. And it's also about really adopting that equity lens and focusing on health and wellness, not just the disease, in conditions that create health, bringing together the social and the health together for the community, for the people. And so here's the exciting part. This main Ontario model is scalable. With strong infrastructure, deep local roots, and system-ready partnerships, community-based agencies such as Care First are ready to stay at the heart of Ontario's health transformations. We've made people feel seen, heard, and understood, and deliver real impact. And so I think let's just keep building on that momentum. Thank you for the time for sharing today.
Thank you very much, Sherlyn and Nathan. for sharing, and what an amazing number of partnerships that have been built through the Care First initiative and through the partnership with the Tamil Canadian Centre and many others. What I think just the strengths and highlighting, I really appreciate, the trust-based and some of the attributes that you mentioned there at the end that really enabled this to be a successful model and a lead agency model. We're going to turn now to Southeast Ottawa, and for those who've been following, Southeast Ottawa has been active for a very, very long time in this space. They have some very high priority communities and really meeting the needs. So Amanda, Fatima, and Rana are going to share their story, and so I'll turn it over to you, please.
Thanks so much, Professor Wooditch. My name's Amanda. Nice to see everybody. We're really happy to be here. Yeah, we're here to talk about one component of what really worked well. We as it was said, we've been involved in this space for quite some time. At the outset of COVID, there was actually 5 were identified as high priority communities just within the catchment of our community health centers. So we really had a lot of experience at the outset, even before we had these terms like community ambassadors and those kinds of things. But today, that's what we're here to share with you and talk to you about. And it's really these sort of strength-based, culturally adapted leaders from the community guiding us and leading us and creating trust and doing those critical pieces that without them, we wouldn't be here today. We wouldn't have been made such great strides in our approach and turned out to be quite a critical piece of our model. And not just this model in terms of COVID and cancer screening and other population health, but we're incorporating this into many, many more programs and models, which is proving to be really valuable, relevant, and successful. So I'll hand it over to my colleague, Fatima.
Thank you, Amanda. Just making sure. Oh, perfect. So a little background on the community development framework. It started in the Southeast Ottawa Community Health Center's Banff neighborhood, and it's now expanded citywide to support 56 priority neighborhoods and involves over 30 partners from housing to community health to public health and grassroots groups and tenant circles and so on. The CDF, again, like I said, is an initiative of the Southeast Ottawa Community Health Center with the objective of involving and including and building the capability of residents to work alongside community development staff and community health partners in order to realize better outcomes with respect to mental well-being and health. And so the CDF, we coordinate, we provide guidance, we build capacity, we train both residents and staff to work in this way. And since 2012, the CDF has trained 350 resident leaders to build stronger communities. And the resident leaders whom we train are generally active volunteers in their community partners who are frontline identify as engaged, and we solicit their involvement in our capability building training, and through their training, they are then able to go back into their neighborhoods and help us better realize some of the objectives of improving mental well-being and health in communities, and also to help us realize what the community is looking for and meet the needs of the community. And so it's critical in the way we work that residents are not just consulted, that we move beyond consultation with residents, but we actually bring them in to co-shaping and co-designing the approaches the objectives and impacts we seek to have, and the approaches we take to realize those objectives. And speaking of resident leaders, I'd like to pass it to an esteemed resident leader who we have with us today, Rana Tahir.
Thank you, Fatima. Thank you for giving me this opportunity actually to speak on behalf of the resident leader.
Thanks, Fatima and Rana. I'm just going to cue you with some questions. So can you share how you started and became involved as a resident leader?
What inspired my involvement in the community, actually, it was the opportunity to learn more. So it was a two-way learning, to teach myself first, and then to teach my resident leader, or the resident themselves. So it gave me the opportunity actually to learn and then to spread this learning around me. This is the first thing. The second thing is it was actually the teamwork that we learned from each other. So everything I want to learn, I sometimes pass my questions to my colleague, to my manager in the community, to my friend, and I asked a lot of questions actually to educate myself, and yeah, I got this support actually, and I got this beautiful opportunity.
Thanks, Rana. And can you share a little bit how this role made a difference and the value it brought to you and to the community?
Yes, actually, it was the trust between me and the resident themselves, that they trust all the information I provided during the period of the COVID period. This is the first thing, and actually even the trust that I built it between me and the Ottawa Public Health themselves. This is the first thing. The second thing is helping newcomers because they came with a lack of language, with a lack of information, and we lead them to the community, to the services that the community have, and even answered most of the questions they came with, and educate them with some of the information that we have it from Ottawa Public Health and the community.
Thanks, Rana. And can you finally share a little bit about the support you received and how that transformed into co-learning?
Actually, I started as a volunteer in the community, and but I got a lot of support from the community, from Ottawa Public Health, from my friend themselves, because they trusted me and they trusted the information I provided, and then I just put this information wildly to the community themselves, to the resident themselves. I got a lot of support from a lot of schools. One day we reached out to 600 students in one day, and we provide a lot of information about hygiene, and we answered a lot of their questions. We got a lot of support from Ottawa Public Health, as I said, and yeah.
That's great.
That's all.
Thanks so much for sharing, Rana.
Thank
We're
you for
so happy to have
Thank
to have your story as part of some of the key values that community ambassadors, or what's sometimes called or resident leaders, bring. And trust is a big one, where residents may not trust the medical system, government. They will trust, more likely to be open and have conversations with members of their community, their friends, neighbors who speak the same language, share some lived experience, maybe have religion or faith-based affiliations in common. And some key initiatives that our community ambassadors were part of, staff too. I was part of many of them, Fatima as well, and many others, but door-to-door outreach when things were closed. Conversation circles. These is where we got feedback from residents and resident leaders about what was working, what their biggest barriers were. And these were safe spaces where they would sometimes share things that wouldn't share in other more, in more formal meetings. We were also communities of practice were born out of these initiatives. So we now have, and what's now become part of OHT, which really highlights the integration piece. We have an OHT-driven community of practice that's monthly, but when there's flu season or during COVID, they were more frequent, and just formalized those partnerships, the voice of community that really drove action and helped us. We worked together to layer different key data sources like the spread of COVID or the rates, the different income levels or barriers to different supports in the community. Another piece that was born out of these initiatives are networks and WhatsApp groups with newcomers, where they could more quickly connect with people that shared their language, that shared their experience in navigating, settling in a new country, a new home with their families or individually, and were more quickly able to access supports. So in many of these initiatives, it really brought the door to the community. And that was critical during a time of isolation. That was also critical for any population groups that face increased barriers and for different reasons, maybe sick leave, maybe transportation, maybe access, may not always be able to access the supports that they need. It was culturally appropriate. When Rana was talking about her experience, they're culturally adapted. So our community leaders spoke the language, could identify with the culture and shared experience, which was one of the pieces that created trust. When we initially partnered with public health to give out brochures, to give out screening or rapid tests, people would maybe agreeable at the door, but would share with resident leaders later on that actually I'm not, I'm reluctant. And that opened the door to have those conversations as to why, and to later help build our success in some of the data that I'll share with you in a minute. But it's really that understanding of lived experience and neighborhood strength, and this improved our ability to reach isolated or reluctant residents. And although it showed us the importance of just amplified how critical it is to bring those critical supports, messages, and follow the community's lead, have that strength-based approach. Where are those leaders in the community? What are the strengths they can bring? And how can we let them show us how to do this? And that worked beautifully. And then in terms of impact, we pulled together some data. So since we started this work, and as Fatima shared, we've trained over 350 resident leaders, which is huge because they'll have each their own communities. They're each have their own interaction. So it's like that pyramid where it's like that water droplet effect where that impact just spreads exponentially. We have more resident-led, more residents who lead, volunteer, and participate. So it's really increased the engagement at a time where the rest of the world was seeing less and less. We tracked some of our initiatives. It facilitated the delivery of over 6,000 vaccinations to underserved populations. And we had to create very unique models to be able to do that, like going door to door or doing pop-up clinics in vulnerable neighborhoods. We reached throughout the different initiatives. This is an underrepresentation because we only got good at starting to track these things partway through, kind of building it while flying it, but we reached over 255,000 residents in Ottawa, which is huge. And we distributed over 5,500 rapid tests just in the Heatherington Cedarwood area, which is one of our communities that we prioritized. Our community members reported better health, better mental well-being, and access to food supports during this time. And it created more activities and spaces to connect. So here's some examples. We had the WhatsApp group, communities of practice, and community events. And this is a photo of a number of our resident leaders and staff, and everybody's masked up. And this is in a different community within Ottawa. It's Rideau Rockcliffe Community Resource Center and Ottawa Community Housing. So you can see that in public health, we have a lot of partners, resident leaders, and doing a lot of wonderful work, doing that co-learning, establishing those partnerships and bringing those critical services to community. So thank you very much for the opportunity. We were really happy to be here and share some of our experience.
Really, so thank you very much, Ottawa team particularly. Thank you, Rana, for joining us today and sharing as a community health ambassador your work and your experience and how that has helped to enliven and enrich your community as well as yourself. I think just amazing stories today from the different teams around using data, around developing partnerships, and really leveraging the community health ambassadors to maximize like such strength in the community and strength-based approaches, while also strengthening and creating even more capacity within the communities. Thank you so much. I've got a question that I want to ask for people who are joining us today as participants. You know, there's over 100 people online, 150 at the peak today. Are there ideas you're hearing about today that you'd be interested in implementing in your communities, or even just generally, you know, what's a little bit about some of your takeaways from these first couple of stories? You know, these are 3 of 16 programs that have been out doing this work across the province. We're going to hear now from Health Commons Solutions about the broader supports to the 16 programs. And I'm interested in knowing, you know, some of you may well be representing those other 13 programs or just doing other work either through Ontario Health teams or otherwise. Maybe you could like name a little bit if it's an Ontario Health team or if it's another community program, and maybe what you're kind of taking away from today. I'm hoping we can have Sophie to join us now. I see you there. And thanks very much for joining us. I really look forward to hearing, because you've been supporting these groups since day one, what we've learned.
Thanks, Walter, and thanks to my colleagues from across the lead agencies. Just, I'm not going to be able to say anything that comes close to matching the degree of like specificity of what it looks like on the ground. And I think even just what makes it super interesting to pay close attention to the locally driven population health management model. But I can share a little bit of what it's been like to be sitting in the front row seat and watching this unfold across the province. And I think one of the most important ways to really capture the benefit of what the LDPHM lead agencies have been doing is to think about where it can go next. And I know a couple of the lead agencies talked about the importance of thinking about scale and thinking about how to take what is being sort of developed in the innovation flywheel across these lead agencies across the province into many other spaces. So we can talk about that. I think probably the most appropriate place to think about the expansion right now, just because of the momentum behind it. But also, I think the importance to Ontarians is just in that space of where primary care is evolving. And so most of you, I'm sure, are pretty actively involved in the primary care expansion plan, which is an incredibly ambitious and really exciting geographically based population health model for primary care reform. And from where we sit, we see an opportunity for that strategy to really transform the health outcomes of Ontarians. But I think in order for that to happen, because this is such a very different way to work, and the lead agencies have all illustrated what it means to be closely connected in really integral and authentic ways with the geography that you are in, the communities that are there, the assets that are there, the priorities of the local populations, what it means to be really intimately connected and aware of what those things are, and to really be able to design an offer that is very effective for that community and that level of specificity. That's the particular skill that I think is going to be required in order for the primary care strategy to really meet its opportunity and to really meet its full potential. And so as we think about where the primary care reform is going, when we look at the LDPHM strategy, there's a lot of parallels that we think create great opportunities for learning, mutual learning, and even scale. In order, I think, for primary care to really generate, the primary care firms really generate the kind of value that we are hoping to see out of it, in addition to attaching so many people, is to really think about how do we get to those who definitely need care the most. We know that there's probably going to be a gap between the number of people who can be attached and the amount of funding that is there just because of retirements and population growth. So part of the question is, how do we ensure that everybody is getting access, and those who maybe need the deft hand of a primary care provider guiding them through their journey get to the care in the most efficient manner possible. And so we see LDPHM really being an engine for some of that learning, and an opportunity to learn. And I think Walter talked about, like, are there strategies that you'd be interested in deploying in your own geography? There's a number that we would like to highlight. I think everybody's talked about this, but I think one of the most important questions when we think about equity is, how do we think about access and equity, and who requires that extra care and attention when it comes to service design? So when we think about this question, we often think about the very small and specific but critical population of Ontarians who have two key factors. One is that they are impacted by the social determinants of health, and those social determinants of health are negatively shaping their health outcomes, and also that they have poor access to care. So often they live in areas where there may be low rates of service provision, but they also may be in areas where there's a lot of service provision, but it's not necessarily designed for their unique needs. And we heard a lot of about the work that lead agencies were doing to culturally adapt programs to make sure that they had the right robust network of partners to meet people's range of priorities and their preferences and also their needs. Sometimes it's as simple as the hours of operation or going to where people are. Lots of great examples about mobile outreach, pop-up, taking the approach of wellness clinics and thinking about health in a really holistic and robust way that matches the way that communities think about their health. So when we think about equity, we think about this sort of combination of strategies that are required to address both the social determinants of health and also the access question. And I use this slide regularly. I think part of the reason why it's important to focus in on this population is because, in addition to the fairness and the justice of providing good quality care to these communities, there is also a pressing question around sustainability of healthcare that we are constantly facing in Ontario and I think around the world. And here in Ontario, there is a modifiable spend. That means that with better primary care and with better and more comprehensive wraparound services, we could really impact about $36 billion worth of annual spending just on this population who, as a result of poor access and because of the social determinants of health, end up with a pretty large footprint in the healthcare system. Just pulling from the available data that we have right now, we know just focusing in on some improved primary care for some complex patients could have the impact of significantly reducing emergency department visits, but also hospital admissions, and also have a real impact on what we currently spend in diabetes care management and heart failure. So we've been playing with these numbers and with this concept for now almost a decade and a half, and tracking all the way back to Health Links. What's exciting about the LDPHM is that it is really getting us very close to a model that allows us to tackle that at a very local level. So I'm often asked whether or not the LDPHM is just about community ambassadors, and it's actually not. It's three really important elements that are deeply intertwined. And this is the model that we have to share back with the ministry when we talk about the opportunity to expand this initiative. What is often not said about this initiative is that although it's now been expanded to 32 communities across the province and 32 lead agencies, the spending on it has been fixed at about 25 million. There's been an accumulation of spending of about 180 million across these communities, mostly through COVID. But it is a small bucket of funding when you think about the $1.8 billion that goes into primary care. What has made it incredibly successful, I think, is what sits at the center, which is the local leadership. And you've heard leaders in this call talk about what their role is in pulling together this effort. So the center of it is the lead agency, an organization that has been named with the key responsibility about thinking about how they're going to pull together the effective collaboration that's required to address access and the comprehensive and wraparound care that is required. So that lead agency is often named because they have very strong relationships with their communities, because they have a very deep and authentic connection to what is going on the ground. And they have clear insights into the behaviors, the culture, the preferences, even the desires of their communities around what health can and what it should look like. And so part of their role is, and I think in a complex problem space, which is what we often see in the health equity space, which is sort of the intermingling of social determinants and access and system factors. Part of what we actually see is their responsibility is this pulling together of the collaboration of a huge network of partners. So Care First talked about this, East Toronto Health Partners talked about this, Ottawa highlighted their relationships. They've named thousands of partners across their network who are in the healthcare, the formal social care space, but also just in their community spaces, faith-based organizations, community organizations, schools. Part of that collaboration means finding and identifying who is best positioned to reach communities we may not be seeing or provide a particular aspect of the service that is required. And then that collaboration function, which is who and what will they do and when. The other really important element of their success has really been this getting care on the road piece. So making sure that we have culturally appropriate and culturally adapted outreach, as well as mobile outreach. And so a central feature of that, and you've heard it so beautifully illustrated here, is that community ambassador role, often also called the community health worker role. And I think it's important to note, we know this really clearly. Community health workers have been around for a very long time, but this is the first time we've really seen government get excited about scale and think about how that role can be deployed in different ways. And so those three elements in concert are part of what really is the magic sauce of the LDPHM. I'm not going to spend too much time because you'll see this in the notes, but talking about what it looks like on the ground, because you've just heard really good illustrations. But I do want to take a minute just to pause on the piece related to building trust. And I think it's an aspect of the work that lead agencies have been doing so well. And in many instances, building that trust has also been a key function of the Ontario Health Team. So where we have seen lead agencies be most successful, there's been a very strong relationship between the lead agency and the Ontario Health Team. And in these instances, often what the Ontario Health Team is bringing is not the planning and the population, population-based design. What they are bringing are the acute care service providers to the table around how will the referrals work? How will we ensure that people can get access to the first available primary care spot that opens up? So they've been playing this other role other than sort of the planning function, often handing off that planning and design of care for these communities to the lead agency, but thinking about the ways in which they can broker access for the populations that are being identified, just smoothing of the transitions around the care pathways, and really playing that role of convener, really ensuring that everybody is at the table, problem solving actively. I think Nathan talked about this, actively problem solving the questions around access and service navigation. Just a couple of final notes, and you'll be able to see these in detail. Because we are thinking about the evolution of the LDPHM as it shifted out of the pandemic into cancer screening and thinking about getting people's health back on track after the pandemic, and now really focusing in on how to support the provincial efforts around primary care. There are a number of efforts that these lead agencies are really tackling in terms of helping to address attachment, but also provider retention. So these lead agencies are often operating in areas that have low rates of primary care providers. And it's difficult to attach or to attract providers into spaces where there is no safety net. So part of what these lead agencies are doing is really making that safety net very visible, high functioning, and they're providing care to people while they are waiting for primary care expansion to take place. They're also doing really active things to get people ready for sliding into a primary care spot when it becomes available, and working very hard to ensure that people still have access to care while they're waiting. So we've seen a lot of different iterations of that. There's some beautiful examples shared here. We just wanted to talk about some of the specific things that we see lead agencies doing on the primary care front, really looking at mobile care teams that can provide episodic primary care, that can go into geographies and areas where there is very little care or where we know there are very high rates of attachment. In many cases, those teams are doing medication reconciliation, they're doing a complete history for patients, they're stabilizing the social care needs, and they're stabilizing the individual while they wait. We've also seen community ambassadors do a really good job, and Walter talked about this. Sometimes there's a referral to primary care, but it doesn't actually land. And part of what the community ambassador can do uniquely is provide a very high touch interaction that builds trust over time. We've heard community ambassadors talk about, sometimes waiting in the Tim Hortons 2 or 3 times for being stood up by the same person, only to find the 4th time is the time that really clicks for that individual, where they know you've shown up for them a number of times and they can trust you. And then suddenly you see care open up for not just that individual, but their entire family unit. And that very high touch interaction that's out of a community space or a clinic space and in the community is pretty unique. It's something really special that they are bringing to the mix. In a geographically based model, it's going to be very important in order to make sure that we can reach folks who are otherwise not being reached. And of course, they bring the allied health professionals. The other thing that I really don't want to, I want to make sure that we are not underselling, but we're really highlighting, is the critical role that the expanded network of health and social providers and community partners are playing. So, it's reasonable for primary care and for the healthcare system to say that they can't be all things to all people. And so part of it is brokering access, navigation for individuals, but also the clear relationships for how people will move in and out of the social service requirements that they have. And they've been stepping up in incredible ways. So we see those partners as really intrinsically invested in the health of their own communities and willing to do a lot. And it's really showing, I think, in the benefits that are playing out with the LDPHM. One last thing, because I saw Walter come on. We are in the process right now of putting together toolkits for any of the primary care Ontario health teams that may want to take some of the learnings that have been generated out of the lead agency experiences. So all the toolkits that have been generated with the lead agency partners, even things like jobs or descriptions for community ambassadors, community health workers, just to help you get up and running. Those tools are coming together, but we would love to hear from you. What would you want to see in those packages? Because as we prepare them, we can guess, but nothing's better than just asking you. So I'll leave that with everyone here. Thanks, Walter.
Oh, thanks so much. And really, I think crystallizing key lessons looking forward and placing the model in today's, policy context. I think these are highly flexible models to adapt to provincial priorities and local, these priorities are like the local needs, right? Like where are we seeing the gaps in care? Where are we seeing needs to be accessible? And I was accessibility for everybody often misses a lot of people because people are not really trying to be quite close to understanding. And you have a lot of appendix and resources in here that will be included in our slides as well. We heard a lot. There's a lot of information to share today. So we don't really actually have time for a panel discussion. I hope some people got some of their questions answered in the side, in the chat. I'm interested in, people's thinking about like, how do things create value? We've been asked a little bit by the ministry, are some of these questions around how do we measure value in these programs? And I usually start that conversation by asking the people delivering the programs. And I think we've certainly learned today a lot about capacity building and trust and partnerships, as well as the counts of the number of people that have been connected with services, number of people newly screened for services, number of people connected with primary care, so many. And I think there's going to be great interest to the valuable bits that you're providing. There we go. So here I've popped into the chat one word to keep it easy for people to respond with your overall impressions of today's event. If you could just drop one word into the chat, we'd be interested in capturing these, and perhaps we might put together a word cloud about them afterwards. It's really nice for me to be back. I've been on a bit of a sabbatical. Some of you may have noticed I haven't been at the webinars for a little while. I was on the other side of the planet for a little bit. So happy to be back here. Such amazing learning in these webinar events. We're going to take August off for the summertime. We'll be back in September. Some of you may know that we did a leadership survey of the Ontario health teams. So we have over 700 respondents from across Ontario, from the sort of governing councils, leadership groups from the Ontario health teams. We'll be sharing those results back in a provincial webinar in September, on September 23rd. We'll make sure we get the registrations out to everybody to be able to sign up for that. It is our fourth time conducting that survey, and it's interesting to see some of the ways things are changing. We will also be doing a series of roundtables within Ontario Health regions to the Ontario Health Team leadership for those kind of more smaller group meetings. But for anybody is welcome to join our webinars at any time. So September 23rd, we'll be back with that. Thanks so much for joining us. People are inspired today. People are impressed today. People are motivated today. So our speakers have done a fantastic job. Thank you very much, and have a lovely afternoon.